Hello everyone, this is Dr. Madhusudan Rao and the program I teach medical students. Today I am going to touch briefly on heart failure, especially in infants and children. Coming to brief note about the features of congestive heart failure. Early symptoms include lack of infant weight gain, difficulty feeding or sucking due to hair hunger, infant irritability and fatigue, tachycardia and tachypnea, increased work of breathing. Okay, because infant cannot take adequate feeding, suffers from caloric deficit, and there will be poor weight gain. In the same way, during feeding, the baby has to hold his breath. So, say an infant suffering from heart failure will fall short of breath. So, he cannot take adequate feeding and develops irritability and easy fatigability. Tachypnea and tachycardia are the features of congestive heart failure. And tachypnea leads to increased work of breathing, again leads to poor weight gain. Then the symptoms progress, resulting in periorbital facial edema. Okay, this is more prominent when a child gets up from sleep, and venous distension or the neck veins. It is difficult to observe in the children under 8 years of age. Hepatomegaly, condition of splenomegaly, decreased urine output, excessive sweating, mottling of the body, sometimes cyanosis, rarely pallor. There are some of the brief points related to the presentation of congestive heart failure in infants and children. We are going to touch them in detail in course of time. Look at this heart showing in failure. That is cardiomegaly. This infant admitted for features of congestive heart failure being examined by the physician. See, it is auscultation that is being done first in the clinical examination of the child with heart disease in order to pick up the findings of congestive heart failure or congenital heart disease. This again, a child admitted and examined for features of cardiac lesion leading to congestive heart failure. Well, again, brief note, symptoms in infant and children. There is little difference. Infant, there is easy fatigability, sweating with feeds, loses weight, that is failure to thrive, tachypnea, grunting, retractions of the chest, and crackles at the base of the lungs, palpable liver, and tachycardia, sometimes third heart sound. Symptoms in older children, easy fatigability, exercise intolerance, tachypnea, tachycardia, crackles at the base of the lungs, abdominal pain, skin mantling, and occasionally pallor. These are some of the symptoms in older children. Well, what is congestive heart failure? It is briefly defined as the clinical state when heart fails to deliver adequate amount of blood to meet the metabolic needs of the body. It is inability of the heart to deliver adequate amount of blood to meet the metabolic needs of the body. That means what is the function of the heart? Heart functions in order to deliver the adequate amount of blood to the tissues to provide the metabolic needs. It receives blood from the body through the veins and pumps it to the lungs to get it oxygenated. In turn, supplies to the body in order to provide the oxygen as well as the adequate nutrients for the growth and energy. When the heart fails to provide adequate amount of blood to meet the metabolic needs of the body, that means heart is failing in its function. When it is failing, it calls for compensatory mechanisms. That is in the early phase. In late phase, failure of compensatory mechanisms with increasing severity of the symptoms. So, there is in early phase there are compensatory mechanisms in order to provide the adequate blood to the body needs. And when the compensatory mechanisms fail, there is increasing severity of the symptoms. What are they? Let us see. Pathophysiology. Based upon the pathophysiology, there is low output failure and high output failure. Okay, with regard to the cardiac output. What is cardiac output? Cardiac output is a product of stroke volume multiplied by heart rate. Okay. What are the factors that determine the cardiac output? Preload, end diastolic volume, degree of myocardial stretch at the end of diastole, myocardial contractility, and afterload. What is preload? Preload is determined by the amount of venous return to the heart. Okay, when there is a reduced venous return to the heart, that is preload is getting low. When this preload is low, there is ventricular filling is less, so ventricular ejection fraction gets reduced, so ejection volume gets reduced, so cardiac output becomes low. Well, preload is determined by the blood volume and also diastolic stretch of the chambers. That also determines the preload. So, when there is preload is good, end diastolic volume is good. That means ventricles get filled up during diastole. Okay, the more the preload, the more the end diastolic volume. Okay, when the adequate myocardial stretch is there with the end diastole, there is force of contraction of the chamber will be good based upon the starting principle. That results in the adequate cardiac output. Okay, these are the factors. Preload, more the preload, better the end diastolic volume, better the end diastolic volume, better the myocardial stretch at the end of diastole. Then myocardial contractility is good. Okay, when the myocardial contractility is good, cardiac output is determined by the afterload. Afterload is determined by the peripheral vascular resistance. When there is afterload is more, heart may not pump all the blood adequately into the circulation. It has to undergo a sort of hypertrophy in order to inject the blood into the circulation. So afterload is determined by the vascular tone. Okay, that's it. These are the factors that are responsible for the cardiac output. low output failure. What is this? Increased preload with elevated end-diastolic volume. Increased preload with elevated end-diastolic volume. Myocardial dysfunction due to increased stress beyond its contractility that leads to low output. Reduced cardiac output. Example, regurgitant lesions, left to right shunts. Okay. In obstructive lesions, starting principle not applicable. Okay. Say there is increased preload and elevated end-diastolic volume. So that leading to low output failure. What are the situations when there is regurgitant lesions? So there is aortic regurgitation. Say there is tricuspid regurgitation. Say there is mitral regurgitation. Okay, and the chambers are trying to eject the blood, but there is retrograde flow of the same amount of blood due to regurgitation. That means, say for example, there is mitral regurgitation. Left atrium pumps the blood into the left ventricle. When the left ventricle is contracting, the blood is pumped from the left ventricle into the left atrium because of the incompetence of the mitral valve. A part of the blood is ejected into the systemic circulation through the aortic valve. A part of the left ventricular ejection goes into the left atrium. So there is end-diastolic volume in the left ventricle is increased because of the regurgitant blood is added to the pulmonary venous return to the left atrium. In turn, left atrium empties its blood into the left ventricle. By and large, the preload in the left ventricle increases and end-diastolic volume increases. Despite the increase in the end-diastolic volume, the amount of blood ejected into the systemic circulation is limited because of the regurgitant jet into the left atrium because of mitral regurgitation. Okay, so regurgitant lesions results in reduced cardiac output even though there is increased preload. And also left to right shunts. Say left to right shunts. What is happening? Left to right shunt. There is, say for example, ventricular septal defect. There is blood is ejected from the left ventricle into the right ventricle. That flows into the pulmonary circulation. Returns back into the left ventricle through the left atrium. That in turn is ejected into the right ventricle. Okay, so there is volume overloading of the left atrium and left ventricle, but the systemic flow, that is left ventricular output into the systemic circulation, is getting low. This is again what happens in left to right shunts. Well, as far as Starling's principle is concerned, it works to empty the ventricular contents in regurgitant lesions, but it does not apply in the obstructive lesions because whatever the force that has been generated by the stretched muscles of the ventricle, it cannot overcome the obstruction down there to pump the blood against the obstruction. So Starling's principle cannot apply in the obstructive lesions. What is high output failure? Few important points. Systemic oxygen transport is is a product of systemic oxygen content and the cardiac output. Okay, cardiac output is a product of stroke volume and heart rate. Well, in anemia, there is low systemic oxygen content because of when content of the hemoglobin is low and the so oxygen carrying capacity of the blood is reduced and there is oxygen content of the blood is low in anemias. It is compensated by increased blood volume. In the situation with anemia, there is blood volume is increased. It is a compensatory mechanism. Oxygen supply is far below that of the demand that results in failure. Despite there is increase in blood volume, oxygen delivery is limited because of the low hemoglobin content. Okay, that results in high output failure. And then another thing is thyrotoxicosis. There is increased oxygen demand more than the supply because of high metabolic rate. In high output failure, there is fall in peripheral vascular resistance. Myocardial contact rate is normal. Okay, when the peripheral vascular resistance is low, the cardiac output is good, but heart fails because of it has to pump the high volume of blood despite the limited energy supply. In chronic high output failure, increasing myocardial oxygen demand is not met with, so heart fails. Okay, as myocardium requires energy for its contraction, right? When the heart is working with a high blood volume in order to pump in the conditions of high output failures, it works for some time. Later on, its energy supply is limited, so it fails. This is what happens in low output failure and high output failure. Remember one point. In low output failure, end diastolic volume is good, but it is being pumped into the chamber from where it is receiving the blood. That is, there is retrograde flow of the blood into the chambers. That results in the reduced blood volume being pumped into the systemic circulation. That results in low output failure. Whereas in high output failure, there is blood volume is high and oxygen delivery to the tissues is limited. That too to the myocardium. In the course of time, because of the limited amount of energy supply to the myocardium fails. That is called high output failure. What are the compensatory mechanisms? These mechanisms will set in at cellular level, at neurohormonal level. Okay, there are certain beneficial effects of the compensatory mechanisms, some disadvantages too. At the cellular level, alteration in oxygen utilization and other substances of metabolic pathways. So, cells starts working to deliver the energy in low oxygen environment. So there could be anaerobic oxidation instead of aerobic oxidation. anaerobic metabolic pathways instead of aerobic metabolic pathways. That results in the uh, situation called metabolic acidosis. Metabolic acidosis leads to vasodilatation. Okay, that limits the functioning of the tissues, including myocardium, when it is prolonged for a longer time. Then neurohormonal pathways increases sympathetic activity. Okay, renin-angiotensin adrenergic axis is stimulated because of the heart is failing initially. In order to maintain the that is cardiac output, there is sympathetic tone is stimulated and heart rate increases. In order to increase the cardiac output, heart rate increases in order to improve the cardiac output, that is minute volume. What are the benefits? Increased beta intrinsic action, increases heart rate and myocardial contractility. That to some extent it is good. Increased alpha intrinsic action, it leads to peripheral vasoconstriction. This is beneficial to some extent because the blood flow is diverted from skin, kidney and gut to brain and heart. Okay? But this is associated with hypermetabolic activity, increased oxygen consumption, increased afterload because of peripheral vasoconstriction, then myocardial damage and arrhythmias. Okay? You cannot whip the sick horse for a longer time. If you keep on asking the heart to function with additional load, that is, with increasing peripheral vasoconstriction in compensatory mechanism due to increased adrenergic flow, that results in the increasing afterload. Okay, that again stress on the myocardial contractility. So myocardium has to work against increasing resistance. That leads in course of time heart failure. Coming to clinical manifestations. So, well, in the compensatory mechanisms are when called for, the patient will feel breathless, palpitation because of the racing heart. Okay, his exercise tolerance will be limited. When he wants to do the normal exercise, heart starts racing. That leads to a sense of palpitation and breathlessness. So he has to take rest at that moment of time. Over time, when the heart fails, the clinical manifestations of heart failure, they differ slightly from infants to children and adolescents. What are they? Infants come presents with feeding difficulty. While the infant starts to take feeding, there is, he has to, breathing will become difficulty. That results in breathlessness. So that is the reason why infant with congestive heart failure, there is feeding difficulties. Excessive perspiration is the finding you naturally seen in the infants with congestive heart failure. It reflects the high adrenergic outflow. Respiratory distress. poor weight gain, and infant becomes irritable and cry is weak. Infant is hungry but he cannot take adequate feeding. What will be the situation? He will become irritable but cry is weak because he does not have adequate energy to cry. This is the pathetic situation of the infant with congestive heart failure. In children, you cannot play as much as the co-children, so feels easy fatigability, effort intolerance, so breathlessness, okay, cough and chest cramps. Cough is because of the excessive bronchial secretion secondary to the congestion in the lungs. It also results in wheezing and cough. Okay. In adolescents, abdominal pain, nausea, anorexia, absence of respiratory symptoms. It is like this. When the heart is failing, there is end diastolic volume is getting increased. Okay, that results in the increasing pressure in the venous circulation. When the left atrium is unable to empty its contents and the left ventricle is failing and left atrium is unable to empty its content in the left ventricle, there is a backward pressure from the left ventricle to the left atrium, from left atrium to the pulmonary venous system. So the congestion in the lungs that results in the left ventricular failure secondary to the transmission of the backward pressure. Increasing pulmonary venous congestion leads to orthopnea. Orthopnea means when the patient is asked to lay down, he feels breathlessness. Breathlessness in lying down posture is called orthopnea. And patient also suffers from paroxysmal nocturnal dyspnea. That means it occurs in paroxysm while the patient is lying down and in deep sleep. He suddenly develops breathlessness and air hunger. And there is crackles at the base of the lungs because of the pulmonary edema. This occurs because of the adrenergic mechanisms or adrenergic outflow becomes dampened during sleep, and so the left ventricular contractility is also reduced. So there is increasing pulmonary venous pressure and pulmonary edema in paroxysmal nocturnal dyspnea. Okay, that is because of the dampening of the compensatory mechanisms which occur during sleep. That results in the sudden breathlessness with pulmonary edema. That is called paroxysmal nocturnal dyspnea. It's the feature of acute left ventricular failure or left heart failure. Left heart failure presents with more amount of symptoms like breathlessness, paroxysmal nocturnal dyspnea, orthopnea, cough, and sometimes hemoptysis, etc. And also palpitation. Okay, these are all the symptoms of left heart failure. When the pressure is increasing in the right side of the heart because of the backward pressure, okay, there is increasing right ventricular pressure, increasing right atrial pressure, increasing systemic venous pressure. That results in raised JVP, presence of hepatomegaly, presence of edema, feet. These are all the clinical signs you see. Okay, right heart failure results in more amount of clinical signs in the form of raised GVP and hepatomegaly, ascites, and edema feet. That's how the clinical manifestations occurs in congestive heart failure. And in children, signs can be raised JVP. JVP can be seen in children beyond 8 years of age. Then could be enlarged liver, ascites, dependent edema, and when you auscultate the heart, there could be gallop rhythm. That is because of the cardiomegaly resulting in dilatation of the left ventricle, and there is third heart sound. Whereas coming to the signs in infants, there is a tachypnea, respiratory distress with intercostal and subcostal retractions. As I told you, wheezing, edema of the eyelids, you can see edema feet, they are less common in infants. You can see the hepatomegaly, tachycardia with gallop rhythm, and signs associated with the cardiac lesion. It could be ventricular septal defects, it could be okay, patent ductus arteriosus, etc. Then go for the workup, X-ray chest. You will find the cardiomegaly and pulmonary congestion. ECG shows the, depending upon the lesion, you may find the left ventricular hypertrophy with left axis deviation, okay, or biventricular hypertrophy in depending upon the underlying lesion. Echocardiography will demonstrate the nature of the cardiac anomaly. Then, having made the diagnosis, how to manage the patient. General measures like diet, diuretics, then afterload reducing agents, digoxin, alpha and beta adrenergic agonists, and with this child will improve. And still the heart failure is resistant to these lines of management. You go for the phosphodiesterase inhibitors, okay, chronic beta agonist use, ultimately electrophysical treatment. General measures. Absolute bed rest is not necessary as a routine except in seriously sick patients. Okay, ambulation allowed after recovery. Prior exercise tolerance is tested before admission into the hospital. Bed position should be orthopedic posture with head and other bed elevated. Cardiac chair for infants. Beta agonist for beta agonists, afterload reducing agents, phosphodiesterase inhibitors, etc. are the line of treatment, but we consider one by one. Supplemental high caloric formula with breast milk, nasogastric feeds in seriously sick infants, overnight gastric infusion to avoid reflux. Okay, avoid nasogastric feeds at night. Instead, give gastric infusion in order to avoid reflux. Strict salt-free diet is not required. In infants, we manage with gastric infusion during night in order to avoid reflux. Coming to diuretics, to reduce preload, to reduce pulmonary congestion and edema. Furosemide is the drug of choice. It's a loop diuretics which inhibits sodium absorption and there will be loss of potassium, contraction alkalosis. Oh, this is very dangerous when you use the furosemide for a longer time. Hyponatremia, because a lot of sodium loss is there in a loop diuretics. It requires electrolyte monitoring and potassium supplementation if you are giving furosemide for a long time. Spironolactone is aldosterone inhibitor, potassium sparing diuretic, orally it is administered. In emergency situations, you can give the furosemide parenteral, but for a long duration of therapy with diuretics, furosemide, spironolactone is advisable to furosemide. Thiazides are also used in long-term diuretic therapy. Added to that, afterload reducing agents like in cardiomyopathies, left to right shunts, aortic matter regurgitations. Okay, you give the afterload reducing agents in order to improve the cardiac output. For this, you go for the AC inhibitors. Most commonly, you go for the enalapril. But hypotension is a complication in this with the use of these drugs. But monitor the blood pressure time to time. But in acute situations, sodium nitroprusside is advisable in ICU patients. Digoxin is commonly used in children with heart failure. Okay, but monitor the side effects like hypokalemia, prolonged PR interval, ST changes, etc. Sometimes there will be GI side effects which have to be attended to. Coming to dopamine, other beta-adrenergic agents we use in the resistant heart failure. Same way, well-known. So, by and large, children are managed with the diuretics and the digoxin, and most of the occasions children will improve only in resistant cases admitted into the PSU in order to get the other protocols to manage the refractory heart failure. With this, we conclude the talk today. Thank you for patient listening. Thank you very much, and see you next time with the next class. Thank you very much, and bye bye.